was this. Still, I found that I couldn't able to make the appropriate movement of this movie, so I just wanted to talk again. So let me allow to do such a things. So this is the picture of the Yokohama cities. This is the slides which I had used last year. What can catheter intervention to do for the sick kids? And about 6 years ago, 2018, in February, uh, groups of the doctors from Indonesia have visited to our places. Dr. Wang Wang, Dr. Miko, Dr. Winder, Yu Fang have visited to our places to have a contact with Dr. Kawataki for the fetal echocardiography. And at that time, I had a good chance to talk with them and had a good friendships. And I found that Dr. Wang Wang had present me of the pictures of Dr. which was taken picture with Dr. Ilpa. I was very glad to hear. So this is another picture, so taking the pictures. Well, as you know, the this is the map of the Japan, and the next to Tokyo, there's Yokohama. So whenever you visit to the Tokyo, just only maybe 30 minutes is right, you will be able to reach to the Yokohama. This is the pictures of the Kanagawa prefectures, which we are now covering. It has contains 8 million peoples in this area. And the middle is the capital. Yokohama is located in just part of the eastern part of the Kanagawa. This is the pictures of our institutions. It has contains 40, 30 beds, and NICU had a totally 44, and ICU for 4 beds, and the high K units for the 43 beds. Well, we have a very beautiful cherry blossom. Uh, 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 the beginning of the April, winter, 5 to 10 degrees. So it's a little bit chilly. So today I want to talk about the what we. Oh, sure. Uh, I would like to talk about the what we can do to doing the interventions with the very severe congenital heart disease. Typically, I would like to talk about the critical PS case first. This is a list of the interventions which we could perform for the saving the life of the kids. Balloon atrial which is for plan for the TGAs, and atrial septum perforations for the intercalated septums, HLHS, or maybe the stent implantation will be required, and a PDA stenting. Maybe PIVS for your HLHS, maybe. And also permanent valvuloplasty, which I will talk about it, and permanent valve perforations for PIVS. And if the patient had a very severe tetanus hollow, we may put the stent among the alveolar stenting, maybe without the valvuloplasty, for the critical S. And maybe we could put the stent among the coarctation. And I would like to talk about that for a very low infant baby. And also we could do the hybrid stage 1 palliations, putting the stents and bilateral bead banding in the simultaneous fashions. So this is the what we call critical PS, which means that there is a very severe pulmonary valve stenosis, and it could not supply the adequate pulmonary flow via the stenotic pulmonary valve, and it's required a PDA wide opening to get supply from the outlet. So if we want to close, if we want to uh, patient to be get to the home, discharge the hospital, we should have let them PDA close. Then we should open up the stenotic valve permanent valve. This is the picture which we had done, and as you can see that the before the interventions, the outlet pressures of the right ventricle was 72, which at that time the systemic pressure was 60, which means that the pressure of the alveoli was the suprasystemic, and the main PA pressure was 16, so that the pressure graduates was just around maybe 45 or so. And after the balloon dilatations, with using three types of balloons, we were able to reduce the alveolar pressure down to the 23 or so. And here, I would like to show the picture here, something like this. As you can see, the right ventricle volume is quite reduced because of the muscles are in infundibula are very hyper is very rich, and then because of this, the volume of the right ventricle is getting reduced. As you can see here, there is a very small, tiny flow, antegrade flow among the peripheral vein here. It may be difficult to see, but see, something like this. It's very small. As a measurement, we show that the volume of the right ventricle was just only the 65% in normal. But fortunately, the patient would not have sinusoidal communication. If there is a sinusoidal communication, doing the right ventricular angiography, there was a communications should be appeared between the small right ventricles and the coronary arteries. If there is a sinusoidal communication, at this moment, the coronary artery could be get observed. If we found measured sinusoidal communication, we could not get able to reduce the right ventricular pressures, because if once we reduce the right ventricular pressures, they maybe the coronary artery pressures will be decreased, and it may cause cardiac ischemia. Maybe MI maybe happen soon after the intervention. So it's quite very dangerous to perform the valvuloplasties who had a major sinusoidal communications. We have to be very careful about that. So what we had done, there are several ways to get approach to those stenotic part. We had inserted the microcatheters inside to the ventricles, and then want to get very slowly close against the arthritic valve. As you can see, it will go very nicely against the permanent valve, and then we let them a very small wire, uh, 001 coronary guide wire, Agosas guide wire. And then once we were able to cross the permanent valve with the 001 guide wire, then we just let them insert the microcatheters inside to the descending aorta. And there is a very good tips. If you will may be able to pass through the microcatheters,
Ditujukan kepada pasien atas nama Baisya Miraati dan Muhammad Arsya Karazik dituruh di poli anestesi. Kami ulangi, berita panggilan ditujukan kepada pasien atas nama Taisa Miranti dan Muhammad Arsya Arazik ditunggu di poli anestesi segera. Terima kasih.
Uh, if you will be able to pass through the PDA and then inserted the microcatheter inside to the descending aorta, and if possible, if you get let them down to the femoral vein, you may compress the guide wire, maybe you may compress the magnetic catheter, which make you can make a um AV loop very easily, and it makes a very interventions very easily. So it will make the strength of guide wire support strong by delivering the balloons. So if possible, please able uh place the tip of the guide wire downward as far as you can. And then typically, if possible, uh, I would like to recommend to use the 2 to 3 millimeter balloons, which may, during the inflammation here, you can make the holes wider to let the next balloon cover easier. So, the, uh, of course, if we don't use the smaller balloons, maybe we can insert maybe 6 or 8, but still we'll feel very big resistance delivered in the balloons. So want to make a small hole on the stenotic valve and let them next balloon deliver easy. So here now I'm now uh trying to inflate the balloons with the 6 millimeter balloons, and then finally with the 8 millimeter the balloons, something like this. And after that, the saturation, which was just around maybe 80% of the so, was just elevated to the 92 percentage without using any air, any oxygens. And 2 days later, PDA close was observed, and then patient was safely returned to home. This is this final pictures of the PHA. And this moment, please check for the mild PR because of the mild PR, it may let the small artery growth. But please do not over-dilate the valve, because if you do too much, those excessive PTPV, the balloon will hurt the alveolar outflow tract, resulting in the alveolar OTO. And I have seen that the cases who had required the surgery's repair of the alveolar outflow tract. So next case is the PIVS cases. As you can see here, this is the left-sided images. Very small hypoplastic left ventricles, and the atretic pleural valve here. And the right-sided pictures is that that means that there is a communications of the alveoli and the coronary arteries. If you put the contrast among the right ventricle, and then contrast will enter the coronary artery, it means that there is a major sinusoidal communications, which means that it's not indicated for the PTPV anymore. So maybe in such cases, we should go ahead for the front operation to abandon to the biventricular repair. So in the right-sided images were considered to have a out of indication of PTP movie. We just let them go for the front operations. And so looking for the sinusoidal communications is very important. Here, there's the pictures of the membranous artery here. As you can see, there is a pleural valve here, but it will never open. There's a here, PDA here, but it will go downwards, touching to the pleural valve, and then go downwards to the both bilateral PA. This is the PDA for the long unwinding. It's very typical PDAs. So whenever we see those cases, we just do for the OOs or LVGs, but we never forget to do the AOG because the AOG is the most effect had a very good images, beautiful images PDA here. You can see here the 3D uh, autography here through the PDA. Uh, it will go fill with the permanent artery and see how the permanent valve are. And looking at here, you will be able to understand that the catheter, JR catheter, is just now right now touches in the middle of the permanent valve under us here. So it means that it could be able to, if we could perforate at this part, it should be the best place because if the catheters will be touching over the upper side, it may protrude into the alveolar upper tract, which cause the tamponade, and that's the worst things we should avoid it. So every time we do, we just ask for the echographer to be sure that the catheters is touching in the middle of the permanent ball. And then we proceed the radio frequency guide wire. This is the uh, end of, and it had uh, perforated, and it had proceed into the femoral artery here, something like this. And it happens in a very quick. It just take only about 2 or 3 minutes, 2 or 3 seconds, say. It suddenly entered into the femoral arteries. So the most important thing that those kind of radio frequency guide work, it should makes the procedure very easy, but still it makes a larger hole than the typical regular guide wire. So once you make in a wrong place, such as the alveolar outflow tract, the tamponade would happen, and I think to get controlled tamponade should be very difficult. So I thought that the uh, recently I found many countries interventionists, especially for the ASEAN people, who would feel that they to avoiding to use this radio frequency guide wire. Of course, it works very nicely, but still, it has a great risk, and we should understand about that. So we should be very careful during this kind of the procedures. So here, beginning, I've just dilated with the 2 millimeter balloons to make the pathway to like them to next balloon delivery much more easier. So this is the wrong. The next case is the critical is an endocardial fibroelastosis and had a PDA. The right-sided pictures, images, is the typically critical is. As you can see, the symptomatic outlet valve here, but still, if you leave it alone in the fetal period, the LV will be dilated, such as the right-sided images. And then the left ventricle will be dilated and lose its power and cannot contract cells. So it should be expanding such like a sac. And inside the left ventricle, the endocardial fibroelastosis will happen. So if once it happens, it should be very difficult for the LV to get uh, to use this LV as an LV. It may not make enough pressures to maintain its adequate systemic pressures. So looking at those kind of pictures, during the fetus, maybe in such cases, we just abandon to the five ventricle repair, or then we just ask for it to seek the possibility for the frontal operation. And this is the most difficult cases to get survived. But still, looking at patients, I just wanted to see that whether there is a possibility to get them elderly improved or not. So the first thing we had done is to keep the foramen ovale to wide open because at this moment the congestion of the femoral vein would happen soon after birth. So first of all, as you can see here, there is a interseptum here, and then this is a widely dilated elbow, which means that it has lots of contraction, and the inner part is is, cons- is quite bright to me here in the kind of cushions. Is has a very connected tissues, rich of connected tissue, which means that fibrosis have happening in this elbow. Here you can see this is the mitral valve regurgitation, very slit, which means that the amount of the blood which pass through inside the mitral valve is very limited. So the airway function does not work it anymore. Another pictures of the mitral valve regurgitation. Here you can see the very hypoplastic aortic arch here, which means that this disease or this location has a very near to the HLHS sequences. So it should be we should make the PDA open. Here, this is the pictures of the LV here. As you can see, the the LV doesn't have a good power to let them contractions, right? And there's a small interatrial communication here, which means that if those communication will disappear, then the um pervading congestion will happen soon after. So to treat with these cases, I just put the stent among the restrictive atrial septum to let them keep wide open. That the if we once we put the able to put the stent among here, the pulmonary vein will get passed through to the RA very easily. But without the stents, at the beginning we just do the only for the balloon dilatations for the very restricted PFO, but it didn't work so much. So that's why I tended to put the stents for to keep wide opening for the age receptors. And then next we had proceed for the balloon dilatations. As you can see here, there is a aortic valve here, but it doesn't seem to be keep open. It's just only closed. So I just let them guide wire and then make a balloon with the 4.5 millimeters uh, balloons. And this is the final pictures of the 4 hours after birth. And you can see there's no AR. The LV was 86 and the outer was 880, which means the pressure gradient between the outer valve was only 6. So this is the echographic image, and you can see that there is no AR. Still, there is a mitral valve regurgitation, very mild one, and the PD no stand which was located intercepted was wide keep wide open. So what was very impressive was the LV function seems to get improved day by day. The most left side was at 0, and the middle was 10, and the at the day of 20, you can see the left ventricles seems to get recovery its power. But still, this happened was the infections to the catheter's insertion, and it happened unfortunately to the patient, and we could not get survived. The patient has died at the half month. Oh, no, no, half an year. But still, the patient could get survived for the 6 months. But still, if the patient was luckily, I think the patient could get reached to the frontal operations. So this is the case of the coarctations. As you can see, the coarctation here, uh, there is a very stenosis among the aortic isthmus here, and because of the stenosis among the aortic, the PDA should be kept wide open to let them PA to the VA, pass through the PDA and then go downwards to the descending aorta. There are two types for the which we call the preductor and postductors, and we have to be sure that which is the type of the coarctations. Uh, the most famous way to treat with was just only the surgical subclavian flap. Uses the subclavian, cut the subclavian, and then turn down, and then covered with the just as a flap, the maneuver flap method to cover the whole extent of the sides. And the most well performed operation is just the extended end-to-end anastomosis, which is very well selected, very well performed in this way. So also there is a option of doing the balloon dilatation of the stem of the side. But what we had experienced was the patient was in between gestational age was 29 weeks, and the body weight just only by 744 grams, which was very low birth weight infant. At the day 9, we had planned to do the pediatric was first, but unfortunately, the coarctation part would get gradually worse. So at the day of the 37 days, the body weight was 970 grams. We should go for the treatment. So at that time, we thought that was the surgical interventions is not option for this case because it was too small. So of course, the only the balloon can be performed, but still these tissues of the outer is very soft, so recoarctation would happen soon after the balloons. So I think the stenting was much more better and much more safer for these kids. So we just asked for the common carotid artery to cut down to surgeons and then let them four French short sheets inserted. And then we measured the what's the pressure gradient or and found that the pressure gradient was just is 40 millimeters mercuries. And this is the primary plan. We just wanted to deliver the 3.25 millimeter corner stent, the low penalty stents, and this was the only size which was available for us. And so after this, the stent should be not good enough. So after, if we were able to place it, the post stent tip is 3 millimeters balloons was scheduled. So the first, we just stent balloon dilatations, which is 3.25 millimeters. And what we had found there was the stent was inflated very nicely, but removing the balloon, the stent migration, what happens soon after. So as you can see here, here the stent here, and we try to pull back the stents with the make a hook using the arc of hook, But still, at the end, it didn't work so much. It had dropped the guide wire had uh, couldn't get able to keep managing the correct positions, and the stand migration would soon after. But still, as you know, this the guide wire maybe doesn't work so much, but even such a guide wire works very well. So my key tips is please do not remove the guide wire in such situations. So what we had done next, just put the additional guide wire as a body guide wire. And then if possible, so using those new additional guide wire, we just let the balloons insertion. And then we found that once we placed the balloon inserted into the stents, we were able to pull back the whole thing with the stents, and then we were able to balloon dilatations at that point. And finally, the stents was placed in very nicely and where we were intended to do it the first interventions. So after the interventions, the stent peak velocity was just only 2.2, and this 5 months later, surgical artery repair into anastomosis of bones. And right now, 2 years has passed, but still no recollectations has been recognized. So at this moment, that I would like to say that catheter interventions is very important for the infant, especially with the complicated heart disease. And combine the other modalities, such as the transthoracic echo, maybe the transesophageal echo, it sure works very nicely. And other, please do not hesitate to perform extra angio, which we have shown that about the PFWS cases, the AOG will help you very nicely, which may provide extra information. And unfortunately, if something wrong happens, or such as the complications, I think the best way is to take a deep breath and keep calm. Whenever I found any such kind of the complications, if the hemodynamics were stable, such as the blood pressure wouldn't move so much, I just asked for the staff for to bring a chair for me. I will sit down for keeping waiting for 2 or 3 minutes to keep my mind calm, and then start to think what's the best option to get rid of these circumstances. So at that time, the interventions will sit down and talk to each other. What's the best way? And keep for talking, maybe through 2 or 3 minutes. The good idea would appear in someone, and then we would apply for that idea, and then it should work very nice. So another thing that please do not move so quick. You know, if something wrong will happen, for example, if the guide wire had perforated the alveolar tract, or maybe if the catheters has stick out of the right ventricles, if you get rid of those guide wire or the catheters, the tamponade would happen soon after. But still, if you place the guide wire or the catheters uh, perforated the alveolar tract, then it will close the hole, right? So you don't have to move it quickly. The worst things is to move so quick. So once you see the stem migrate, just keep the guide wire entered inside the steps. Because once you leave the guide wire through the stent will fall away anywhere. So it should be get uncontrollable. But once you place the guide wire into the stents, it should be something, there's some option to get much more stable for the stents. So that is my final tips. If complication happens, please don't move so quick. Please sit down and think about what we should do next. Thank you for attending. Thank you.
Thank, thank you, Dr. Wida. It's a very interesting
Yep.
class.
I'll be able to.
Yeah, thank you, Dr. Wida. I think this is the second lecture is also interesting to have discussion with, and I do believe you have still a lot of colleagues, professor and doctors who still want to have discussion with you. Um, if there is there any question or discussion from doctors? Okay, Dr. Wida, as you have mentioned before, if there is something happen in as a complication that happens, well, can't lab, um, how to after if there's you say the function of the red wire, we do not have to move so quickly to prevent the cardiac tamponade. Well, what can we do after we have punctured the
Well, I think there are not so many options because I don't know exactly. If you have a, for example, uh, if it is a very severe tendon follow, maybe we can place the cover sense among the alveolar tract. Maybe I haven't such a experience, but still that should be one of the options. And maybe if you uh, perforated something in very small vessels, maybe you can uh, put the coils among the those perforated sites. Maybe we can inflate the balloons and thus reduce the bleedings from the perforated sites and ask for the surgeries. If you move so quick and make the tamponated acute, the hemodynamics will get very unsteady, and you have to resuscitate. Maybe the chest compression may be required soon after the procedures. So I don't want to get in a mess. So that's why I just want to be a little bit leave alone. If the hemodynamics are a little bit unstable, acceptable. So in such cases, to keep harmony, always there are some kind of options. Will get head to each.
Mola saja, mohon perhatian. Dalam rangka merayakan hari ulang tahun dari Sabi Harapan kita yang tepat.
Uh, if the patient had uh, a splenectomy and totally anomalous PV return, and it has a vertical vein stenosis, maybe near to blocked. So soon after birth, the peripheral vein would not get released to the atrium, which means that congestion of the peripheral vein would happen soon after. So we should place the stent among the stenotic vertical vein to release the stenosis site to reduce the possibility of getting the pulmonary congestions. And in such situations, we should bring the patient in a quick, and then we should perform the stent implantations as soon as possible. For example, if there's a critical is, if the patient has not a good PDA wide opening, that should be happen occasionally. We should perform the uh, balloon dilatations with a chest under the chest compressions. So that works just compression and do the balloon dilatation because it could not maintain proper blood pressures.
Okay, Dr. Ueda, thank you very much. Is there any question from audience? Dr. Ueda, you have presented about the coarctation or the management. Uh, does is there any category in your institution which one coarctation or goes to surgery and another or it can goes to the bowel, or is it the bowel only the preaching until the definitive repair of the coarctation?
That's a good question. I think it's just only bridging, but still, if you could able to get place the stent in a correct place, you may abandon the surgery options for longer than maybe 6 months, maybe 1 year or so, which make the next surgical procedures much more easier. The body size will get improved, and then the tissues will get much more stiff. So, uh, as you know, maybe during the operation, the small kids just around below 1 kilogram. Of course, it may worse, but still, the uh, 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 intra- intracranial hemorrhage might happen during the anesthesia, and that's the very difficult thing to avoid. So, to reduce this surgical risk, I think if the patient is very small, we should do the interventions first.
Okay, Dr. Ueda, have any more? Okay, Dr. Ueda, do you have any, smallest case of coarctation ballooning at the smallest ages and or the smallest birth weight in your institution?
I think our smallest cases, yes, I have shown uh, of these cases is our smallest cases, but in the many papers, it's written just about 6 to 700 grams could be performed in a similar method and very safely. So the procedure is not so difficult. So uh, if if the surgeon can perform the PDA ligation, nice, I think they will have a good chance to get place the sheath inside the perfect boundary, and then the procedures of the stent implantation should be very not so big complicated. So I think the patient should be good have a good chance to get survive. And also the balloon, we had propose the balloons among the infants were just only maybe 2 to 3 kilograms. And what we have found there was the tissue of the coarctations would be expanded very nicely with the balloon dilatation only. But half of them will experience recoarctations just soon after, maybe within 1 month, maybe 2 months or so. So it could postpone the Arctic artery repair, but still high volume of the patient might have to receive the corrections of the aortas.
Thank you very much, Dr. Weda. I think we have reached about our time limit for higher lecture this afternoon. Thank you very much for your knowledge sharing. I hope it can bring more knowledge to all of us. Baik, terima kasih untuk dokter, profesor, dan sejawat untuk ikut hadir dalam acara hybrid lecture kita di siang hari ini. Sesi kita untuk hari ini sudah selesai dan semoga besok kita bisa bertemu lagi dengan topik yang lebih menarik. Saya tutup untuk hybrid lecture siang ini. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
So we have done the youngest